First of all, I just want to welcome all of you back to my channel. It has been an awesome last 4 weeks for me. As some of you guys know, or as you all should know, the rotation that I went to this month was psychiatry. And I was a little nervous. I'm not even going to lie to you. Like, it was in a rural area, of course, and I knew it was going to be inpatient psychiatry, which is different from outpatient psychiatry. In my last video, I said that I was going to try and do a video on mental health and its importance in the world, and I felt like that was really important. So, without further ado, I just want to share some statistics with you all on mental health. So one of the number one things that I've seen and that I deal with is anxiety. I mean, how can you go through PA school without having anxiety, right? So anxiety affects 40 million in the United States. 40 million people suffer from anxiety. Depression affects 450 million people around the world. Bipolar can occur with anxiety, and bipolar, if you don't know, is basically, of course, the mood swings, the ups and the downs, the low depressing state and the high manic state where you're distracted, you don't sleep, you think you're on top of the world, or you're the best thing since sliced bread. You have racing thoughts, your speech is pressured, you speak really fast, you have thoughtfulness, all that stuff. That's bipolar. And bipolar 1 is the most popular, which is the manic episode, instead of the hypomanic, which would be kind of depressed episode. And then schizophrenia. That was another thing that I saw the most of. With the 3 positives, like the hallucinations, the delusions, along with the hallucinations, delusion, disorganized speech, catatonic behavior, and your negative symptoms. But the first 3 I named, you have to have at least one of those positive along with the last 2, I guess, for it to be diagnosed as schizophrenia. So the positive, the negative symptoms, which I'll get into in a few. And South Carolina is number 14 in the U.S. prevalence of mental illness. So we're up there on the charts. Out of 50 states, we're number 14. So it's lots of work to be done, guys. So let me just tell you about my initial thought process. Like I said before, I thought it was going to be like prison. I thought they was about to have people locked up. I thought people were going to hurt me, but it wasn't like that. So my experience was nothing short of great. I worked with 2 providers. One was an NP, which was a female, and the other one was a PA, which was a male. And both of them taught me a lot. The other one, the female, I had her my first week. She's very fast, very efficient. She's very helpful. It turns out she just graduated from NP school not too long ago, so she actually knew a lot of my professors. We have the same pharmacology teacher, so we got a chance to joke about that. She took me under her wing like right away. Of course, that's her job, is being a preceptor, but I mean, we immediately clicked and exchange numbers on the first day, which I'm not saying you shouldn't do that with your preceptor. Keep it professional, but it was for like in case I wasn't planning on coming in a day or whatever. But now that my rotation is over, I mean, we text all the time. But anyway, so she gave me a copy of her list of medications that they most commonly use, and she broke it up, the pharmacology, to SSRIs and the antipsychotics, and she had all the side effects on there, and she also starred the ones that practice used the most, which was so helpful. So I loved her. And then the male provider that I worked with, he had been doing this since he graduated PA school, which was longer ago than the lady I was working with, and he was highly knowledgeable. Both of them were. And but he was the preceptor that gave me homework. See, the other one, she really didn't give me homework. He gave me homework, which pushed me, and I felt like when I was with him, I had to come up in there with a certain aura, a certain feel to me. Like I had to come up there like, oh, okay, I'm about to show out. Not in a bad way, but in a way like, oh, okay, I'm gonna show you what I know. and not in a like cocky way either, but I wanted him to know that I took it seriously. I was taking my rotation seriously. I was interested in learning more about psychiatry, because in didactic year that was something that we really didn't spend a lot of time on. So I took it seriously with both providers, but especially with him, because I knew the next day if I didn't look over what he told me to look over, I was going to be embarrassed. I was going to be the one looking stupid. And then secondly, I'm shortchanging myself out of my education. So I did what I was supposed to do. So we saw a variety of patients being said, like I mentioned earlier, anxiety, schizophrenia with psychosis. People hear things, they see things. I seen delusional disorder. We had a patient who thought she was 3 months pregnant, but she couldn't remember the last time she had sex, and she hadn't been sexually active, but she knew that she was pregnant because she felt the baby move. We saw patients that were just really depressed and in some messed up situations. One lady tried to walk in the middle of the interstate and get hit by an 18-wheeler because she didn't want to live anymore. We saw patients that were responding. Those were the fun patients. They would laugh inappropriately and make you laugh, but you had to try and keep a straight face. And then they would also talk, and nobody would be there, but they see things. So it was really cool. We even had a lot of borderline personalities last week. Your personality disorder, that would be cluster B. These people, they want attention. They would do anything possible to get attention from whoever they seeking it from, even the providers. And I've even seen some factitious disorder, or as the old saying was, Munchausen syndrome patients. I even seen one on my last rotation, and it's so funny to actually connect the dots from what you learned in didactic year to what you're seeing with your own eyes and be like, God, I actually did study that for a reason. I think that's the difference between undergrad and high school, middle school. Like, all of it come full force around, and you finally be like, oh, I didn't know that I was going to use this one day. Not saying I didn't know that I was going to use what I learned in didactic, because that would be crazy, because I knew clinicals was coming. But it's just awesome to actually see what's on paper come to reality. First, I had to present. So I had to tell them what the patient diagnosis was and everything like that. And then I had to say, if I thought that they had a personality disorder, what was it? I went over labs. I went over past medical history, review of symptoms, surgeries, allergies, and then what else? Oh, I would tell them past medical history, yeah, that stuff. And then I would say their stressors. Like, why do I believe, based on the story that they told me, that they're in here? So like family stressors, environmental stressors, financial stressors. You just put it like that. We didn't rewrite the H&P. And then at the end, of course, the labs we order all the time on psych patients is HIV, RPR, which is for syphilis, B12, folate, and TSH. And we do that because a lot of symptoms and a lot of psychiatric illnesses can be reversed if it's caused by one of those illnesses. It's nice to know if they have them. And of course, everybody gets a CBC, a blood alcohol, and a urine drug screen. I always do a urine. I loved it. I got to know the staff got to know me. We had the same routine every morning. We would meet as a team, everybody on staff, and talk about every single patient. We had team colors. We had yellow, red, and blue, I believe. Yeah, yellow, red, and blue. We had 23 beds in a unit. And the patient had to meet certain requirements. Like, some people can't come back because they did bad things, and they disrespected the staff, or either we just saw them too many times and they were too difficult to treat or get rid of, or either you know, they just didn't meet the requirements. If they was violent, if they were a threat to the staff or whatever, we would send them, or we would just refuse them, and then wherever they come from, or like whatever ER that they are at or facility, would have to try and come up with another place for them to go. But yeah, that was pretty much it. Then we would make follow-ups. We would see our discharged patient first, then we would do new patients, and then we would do follow-ups. And I would get home like no later than 5 o'clock. I mean, and that was the latest. And some days I got home at 2. So it just depends on what provider I was working with and what the census looked like and the type of patients we had. Medications. I said I would get through that at some point, so here we go. Medications. So you have your antipsychotics, which is used to treat the schizophrenia, the people that hear and see things, etc. Respond. So you have your typical and your atypical antipsychotic medications. Your atypicals are more of the new ones. The typicals are more of the old ones like Haldol, Thorazine, Narvane, Prolixin. And then your atypicals is more like Seroquel, Zyprexa, and Risperdal, and all that stuff. So your first line, which are your first line for psychosis and everything like that. Hold on, y'all, because I'm testing myself to see if I remember. I need to know because my test is Monday. So, yeah, their first line for schizophrenic patients, antipsychotics, and you don't want to use your typicals because they have like side effects like extrapyramidal symptoms like Huntington-Coron's disease, like, you know, the movements and the nausea and all that stuff. So the atypical ones, the newer ones, have less side effects. But in some cases you have to use the typical ones because they're a little bit stronger. Yeah, they run the risk of causing symptoms, but every medication has a side effect. And like I learned in pharmacology before, you have to weigh the risk and the benefit, and you got to make sure that the benefit outweighs the risk. So that's that. We got SSRIs like Lexapro, Celexa, Zoloft. Some are just for OCD like Luvox. I hope I'm pronouncing that right. And then you have your SNRIs like Effexor and Cymbalta. And I mean, the list go on. And then we got certain ones that we use just for sleep like Trazodone. But then it also works for anxiety, or Vistaril, which is a histamine that actually works for sleep and anxiety. And then you have Remeron. You might have heard in family medicine we use Restoril, which is a benzo. And the place I was at really didn't use benzos in their practice. We actually try to keep patients away from benzos because some of them come in there overdosing on benzos, so that's not what we want to do. But yeah, that was pretty much for the medications. I mean, your antipsychotics, your antidepressants, your cognitive behavioral therapy, your psychotherapies, and then there's very few emergencies in psychiatry, but one is NMS, neuroleptic malignant syndrome. So that's when a patient comes in with fever, autonomic disturbance like they can't walk, or tachycardia. They come in with leukocytosis, they have the tremor, they have excessive swelling, elevated CPK, they got delirium, and that is like a major emergency. That, DTs, which hopefully we never see, that's from alcohol withdrawal, delirium tremens. And then you also have serotonin syndrome, when you see a young male patient usually just started on a potent antidepressant, or they come in confused, they're breaking out in a sweat and everything else, and you just have to first stop the offending agent, rehydrate, and hopefully find something else that works for them. But that's what I learned with that. I also have a couple of goodies for you guys. My books that I used. So shout out to my classmates who allowed me to use their books throughout this rotation. I couldn't have done it without you. I owe you my grade, basically. So the one, I didn't even hardly use this one. The one I used is this. As you can see, I have all my little notes in here and whatever. This book literally has everything in it that you need to pass your end of rotation exam and to ace your clerkship or rotation. You don't even have to buy anything else. If you have this book, you already winning. And this book, I kind of use this book as a reference, kind of to see, wrap my head around before I started rotation what type of patients I would see and what type of stuff I might be into, and to read the case study, because the case studies mimic the test questions, and see if I could answer them. So that was that. Okay, and then last but not least, I always take little notes and try to give you guys a little piece of information that helped me, or new things that I learned while I was on rotation, and I might be repeating some of them, so just bear with me. Oh, okay, so here we go. African Americans normally do worse on antipsychotics in general. So at the place I was at, we gave Cogentin when we gave an antipsychotic to an African American, just to make sure. And Cogentin is kind of like Benadryl. It just blocks the side effects, really. Benzoids and opioids, using them together is not good for long-term use or any type of use. In my opinion, I would never do that. It could depress the respiratory system and leave your patient be about to die. Let's see. Circumstantial. People who talk circumstantially. We had a patient that you ask him a question and he'll go around it. Like, kind of like how the politicians do. I mean, they go around the question and they talk about things pertaining to the question but don't really answer the question. And then tangential speaking, they go off on a tangent and they never come back. Blocking, you can't get the words out. They're kind of like take about 10 seconds to answer the question after you done asked it, type thing. And then disorganized, disorganized is when they can't even hold conversation. I had a patient name, and she was awesome. Like she was the perfect picture of a schizophrenic with disorganized thoughts and speech. She was hilarious. I'll share her at the end if I can remember. Do not use Paxil in pregnant women. SNRIs can cause shock in the head if stopped abruptly, like Effexor and Cymbalta. Wellbutrin suppresses appetite, and it doesn't have sexual side effects, but it lowers the seizure threshold. It helps with smoking sensation. That will be on your test or on the boards at some point. Wellbutrin helps with smoking sensation, and a little bit with ADHD. Trazodone can cause priapism in males, orthostatic hypotension. Remeron can cause weight gain and sedation. Vistaril, I already talked about that. That's an antihistamine that can treat anxiety, nausea, vomiting, allergies, skin rash, hives, itching, you know, everything Benadryl can do, and then it helps with anxiety, basically. Prolixin, we talked about that. That's one of your typical antipsychotics, but there's a long-acting form called Prolixin decanoate, which is similar to Abilify, with starting it at PO, and you can also go from PO to the injection. Once you see that they can tolerate PO, go to IM. And then we got Depakote, which is a mood stabilizer. I knew I was forgetting something. Depakote, my bipolar disorder people, you need mood stabilizers like lithium, Depakote, Lamictal. And Depakote can inhibit some enzymes that causes us to be able to get rid of pneumonia, so it affects the liver too. It's metabolized by the liver. And if somebody's on Depakote, you want to get a VPA, which is a valproic acid, to make sure they're not toxic. Same thing with lithium. And of course, we all know that lithium can cause nephrogenic DI, so we want to watch out for that, tremor, and a bunch of other side effects. But it is gold standard from treating bipolar disorder. Prolixin does not cause EPS symptoms as bad as Haldol does, so if you have to use an antipsychotic, maybe want to lean more towards Prolixin. Clozapine can cause pneumonia. It lowers peristalsis. It causes agranulocytosis, so you want to make sure you're getting a CPC every week for 6 months after you start a patient on clozapine. It lowers the seizure threshold, as do a lot of antipsychotics does. It causes cardiomyocytes, constipation. So, and then we have Abilify and Risperdal can counteract and in ways that Abilify helps to prevent lots of dopamine inhibition, thus lowers the risk of having prolactinemia, which is a risk factor for using Risperdal in patients. And then we have Risperdal Consta, which is the long-acting form, and you get that every 2 weeks. And then you can give low-dose propranolol for tremors induced by lithium, because lithium causes hand tremors. Not a lot, but that's what I got, guys. So, I shared at first my initial thoughts on psychiatry, and it scared me half to death, and I feel like this rotation was an eye-opener for me and much needed, because to be honest, some of the people in there really are sick, and they really do like have schizophrenia and stuff that they can't help because maybe it's genetic, etc. But really what I saw more than anything was depression. Life got hard for people, and they just wanted to end it. They just wanted to give up. They tried to overdose. They tried to kill themselves in some type of way. And sometimes a lot of people out here don't have an outlet. They're not strong enough to bounce back like we are, or like some people are. And sometimes you just you can't take it anymore, and that's understandable. It's legitimate. It's not like they're crazy or anything like that, but life just gets hard, and they try to commit suicide, and then they come to the mental health center, inpatient or outpatient, and they get the help that they need. And to be honest, like I shared, I suffer from anxiety. Am I on anything for it? No, because I don't want to take anything for it. But some people, they need medication, and that's understandable. And so, like, I say all that just to say I could have been in there. You could have been in there. Somebody you know could have been in there. We all have ups and downs in life, and we all have lows and highs in life. And we just need somewhere to go, somebody to talk to, and maybe all of us have a good support system and good friends and people to talk to, but a lot of people don't. And I really feel like this rotation was much needed for me to understand, so much that at first I was nervous about it, didn't think I was going to like it, and now I'm actually considering doing psychiatry. So that was a 360 for me. And I hope that the information that I shared with you guys could really help you if you just want to know how psychiatry was for me, or if you're going into clinical year and you want to know what to expect. Of course, everybody's rotation is not going to be the same, because we're all going to be working with different preceptors, different patients, and different places. But this was just my experience, and I loved it. I also mentioned in my last video that I was going to do something saying color in medicine, and I still am. I'm working on the project now. I'm also working on a book, a personal book that I'm going to self-publish. It should be out in the fall, so be on the lookout for that. It's called Unfold My Ashes, Silent Tears That Became My Rebirth. And literally in a nutshell, it's just about all the trials and tribulations I went through in life and how I overcame them things to get to where I am now, and sharing my success and empowering other ladies my age, older and younger, to go for their dreams, reach for the stars, and know that their current situation is not the end. So be on the lookout for that. And I will alert you guys when something else comes out, or I'm on to my next big project, or something happened in school or whatever. But keep me in prayer, because I go to emergency medicine next. And let's hope that I run a cold, but let's not hope that I end up hurting somebody, okay? But until next time, see y'all later. Reese is out.